Hello, my name is Richard Lakeman. Today I'd like to share with you a presentation entitled What Health Professionals Need to Do to Help People in Mental Health Recovery. This was first presented in November 2009 at a conference held at the University College Cork entitled Making Thriving a Reality. The mental health field is fraught with conflict. Mental health, what it means, how it can be attained, sustained, nurtured and developed is contested, as is the role and responsibilities of the state, systems and professionals in not only promoting mental health, but also in responding to mental distress and deviant behaviour. For the most part, what we can agree on is that mental health recovery is a good thing. It has certainly captured the imagination of policymakers, and the promotion of recovery has become an espoused principle or expressed aim of the mental health policies of most English-speaking countries. It was first championed as part of public policy in New Zealand in the mid-1990s and gleaned a foothold in Australia, some states in North America, and more recently in the UK and Ireland. My view is that mental health recovery as a policy platform was approached pragmatically in New Zealand, rhetorically in states such as Ohio, expressed lyrically in policy in Ireland, and received cynically in the United Kingdom. Unfortunately, mental health recovery has multiple meanings, and there is a lack of clarity about what practices support people in or towards recovery. Without some boundaries around what it is, and importantly what it isn't, there is a risk that recovery will become just another rhetorical device, that all and everything will be held up as recovery focused, or as has been the fashion in psychiatric industry, services will be rebranded but not fundamentally changed for the better. This is in part why I detect more cynicism from the United Kingdom and perhaps also in Ireland. In New Zealand, there was actually a radical change to what and how services were delivered. And I thought I would digress briefly, just to point out that recovery became part of social policy in New Zealand and Australia in the context of genuine deinstitutionalisation. Ireland, on the other hand, has clung on to its institutions. Note that Ireland's response to the international trend towards deinstitutionalisation was to build long-stay community residences or hostels. There are more of these than all of the psychiatric beds in 24-hour supported housing in Australia, a population 5 times as large as Ireland. This rapid shift in Australasia forced services to think differently about how they went about their business. It may be informative to compare some other features of the respective systems, and this is derived from the Mental Health Atlas. However, in Ireland's policy document, A Vision for Change, recovery is seen as a principle or value among many. Recovery is apparently a cornerstone of the policy, but just what this means is not explicated in any detail. Presumably, if the various prescribed consultant-led services are put into place, recovery will just happen for people. Whilst recovery connotes something good, and it is liberally dropped into conversation in formal policy documents alike, it is not always clear what we are talking about. The Irish Mental Health Commission's discussion document on recovery, which I might add is a beautifully crafted piece of work, refers to the recovery model, recovery as an orientation, a process, an outlook, a vision, a philosophy, a perspective, a journey, and a guiding principle. In the first incarnation of this conference, it was asserted that recovery is a human right. This is a particularly interesting usage because generally when one makes a rights claim, one is appealing to law, and one is generally making a claim on others. That is, an assertion that others have a duty to provide something, or at least not to actively impede someone from the pursuit of something. In relation to providing for mental health recovery, it is far from clear what professional helpers might be duty-bound to provide. Of course, mental health recovery needn't be ethereal. We can use the term in quite concrete ways and people know what we mean. If I was to say, I'm a recovering alcoholic, most people here would know what I mean and distinguish this usage derived from AA from other common usages, such as my child is at home recovering from swine flu. Mental health recovery is of course closely aligned and at least in part derived from its usage in AA and other 12-step programs in which people see themselves as being ill and in a process of recovery. The term recovery does not appear in either the 12 steps or traditions, but is used in AA literature. So people talk about recovering from alcoholism and successful recovery from addiction. To quote an official AA publication, alcoholism is an illness. Alcoholics cannot control their drinking because they are ill in their bodies and in their minds or emotions. If they do not stop drinking, their alcoholism almost always gets worse and worse. The American Medical Association also has said that alcoholism is an illness. This is a really interesting association with illness, hardly surprising given that AA was founded by a doctor. Presumably, medicine deals with the complications associated with substance misuse, and quite legitimately so. Recovery, however, is primarily the business of individuals and members. Health professionals play a somewhat marginal role in the recovery side of alcoholism, although as an illness one would presume that it comes under the authority and expertise of health professionals. The AA view of recovery is much clearer than in mental health generally, because 12-step programs tend to focus on a single issue rather than all manner of issues and problems that might bring people into contact with health services. Indeed, there is much emphasis on the focus only being on the addiction in AA. In mental health recovery can and does connote positive medical outcomes. The person may be said to have recovered from a particular disease or illness. That is, they don't have any symptoms. Indeed, often in the mental health recovery literature, it is pointed out that people generally achieve clinical, functional, or social recovery with or without medical treatment. That is, people get better. Recovery is also used to describe an objective healing process. The person is said to be in recovery or recovering from something. Things are generally improving. For example, we make a distinction between people recovering from cancer or having recovered from cancer and people's condition deteriorating. A person dying from cancer is not simultaneously recovering. That is not to say that one cannot have a good death, but dying is not a recovery process, and it would confuse things enormously if every kind of developmental process was subsumed under recovery. Recovery is also used to describe a subjective process. That is, I might say I am in recovery, which is pretty much what people in 12-step programs do, regardless of the presence or absence of any particular objective symptoms or current compulsions to use a substance. It doesn't always follow that we necessarily know what we need to do to recover. Then, of course, we have existential notions of mental health recovery, that it is really about finding meaning. William Anthony shaped the idea of mental health recovery with this often cited definition: a deeply personal, unique process of changing one's attitudes, values, feelings, goals, skills, and/or roles. It is a way of living, a satisfying, hopeful, and contributing life, even with limitations caused by illness. Recovery involves the development of new meaning and purposes in one's life as one grows beyond the catastrophic effects of mental illness. Many, of course, have since argued that the effects of being treated as mentally ill are sometimes more catastrophic than any illness, and this creates a complex dilemma. Does one need to accept that one is ill in order to recover? Whilst mental health recovery might largely be a deeply personal process, it is also at least in part a social process. No man is an island. Where I originally hail from in New Zealand, for many people this is self-evident. One is not an individual, one is connected to others, and to lose sight of this interconnectedness is in itself pathological. One critique of some of the ideas around mental health recovery, particularly from North America, is that too much emphasis is placed on recovery being an individual process. This is an understandable ethnocentric bias when a concept is developed in a capitalist, self-obsessed society that stresses individual rather than collective well-being. Mental health recovery is also an interpersonal process. That is, it happens in part between people, not just within them. There is an emerging consensus that this healing and transformation can be promoted or hindered through an interaction between individual factors, for example hope, characteristics of the environment, for example opportunities, and interpersonal factors such as experiencing a secure attachment, supportive and containing relationships, and being connected to others. These conditions arguably are much the same as those necessary to develop and sustain mental health generally. By this we mean the things which are synonymous with recovery, such as living well, taking personal responsibility, engaging in meaningful activities, enjoying supportive relationships, participating fully in the community, and so forth. Some activists have argued that health professionals should butt out of mental health recovery altogether, that this was a concept developed by and for survivors of a hope-sapping, destructive system of care, and that if colonized by health professionals, the concept will be corrupted. This, I think, is nonsense. Mental health recovery cannot be appropriated by any one group. As Phil Barker has suggested, like mental health, recovery must be everyone's business, and as a matter of policy, if not fact, it actually is. So it is important that mental health services consider how they facilitate the right conditions for mental health recovery, and also how mental health services can account and be held to account for this aspect of their role. Mental health workers of all kinds have responsibilities relating to mental health recovery, and they may well fulfill roles that have nothing to do with mental health recovery as well. How can the workforce develop competency and proficiency unless we clearly specify what we mean? Actually, there's a wonderful quote from Alice in Wonderland in which the egret said to the dodo, "Speak English. I don't know the meaning of half those long words, and I don't believe you do either." Unless we have a shared understanding of what we mean when we speak of workers working in a recovery-focused way, we risk going along, or just ambling along like Alice, until we get somewhere, and that somewhere might not be Wonderland. We actually need to develop and maintain a vision of good mental health services and aim to get there. One tool to assist in training mental health workers in recovery-focused practice, and to demarcate particular practices as recovery-focused, is to identify competencies. Competencies are general descriptions of abilities needed to perform a role or job well. A competency involves the ability to meet complex demands by drawing on and mobilizing psychosocial resources in a particular context. The articulation of knowledge, skills, and attributes relating to the performance of roles or tasks can be helpful to inform curricula and training, serve as a source of reflection for self-development, and as a statement regarding the kind of service and relationships that people can expect. Several recovery competency frameworks have been developed that might be considered grand or whole-of-workforce competency sets, such as those in New Zealand, Ohio, and more recently Scotland. To date, there has been little critical commentary about the applicability, portability, or universality of these competency sets. Additionally, middle-range competency sets tied to specific recovery-orientated programs have been developed in Australia, and for particular classes of workers, such as the support time and recovery worker in England, as well as related to particular models such as the tidal model. There is considerable overlap amongst many competency indicators. Many are highly generic and similar to discipline-specific practice standards or the United Kingdom's National Health Service's 10 essential capabilities. For example, working in partnership, promoting recovery, identifying people's needs and strengths, etc. This congruency with wider policy or notions of good practice is reassuring. However, the lack of specificity or concrete indicators mean that there is a dissonance between the rhetoric of policy and what is actually delivered in practice. The project that I'm about to talk to you about was commissioned by the Irish Institute for Mental Health Recovery and aimed to identify a mental health recovery competency set through consensus by people with first-hand experience of recovery, and also to develop brief exemplars or narrative illustrations of recovery competencies in action. The method that was used in this project is called the Delphi method. This is a way of obtaining the most reliable consensus of a group of experts by a series of questionnaires interspersed with controlled opinion feedback. Sometimes in a Delphi study, experts generate an initial list of items of interest themselves. Given that there are so many competencies, I didn't see any sense in reinventing the wheel and instead pulled 103 competency statements from the aforementioned lists. I didn't use the Ohio competencies as there were so many. Experts in mental health recovery then independently and anonymously rated competency statements via a web page in terms of their usefulness and their own personal recovery. The panel also provided definitions of mental health recovery and examples to illustrate competent practice. So who were these experts? These were people who were recognized by others as being in recovery or having recovered well. They in turn invited other people to sign up via a web portal. 31 people formed the expert panel, mostly from the UK and Ireland. 23 reported living in an urban setting and 8 in rural regions. The majority were well educated. Most people reported a diagnosis of a mental illness. 12 people had never been hospitalised. Of the remainder, 7 people had been hospitalised more than 10 times, and people had spent between 3 weeks and 13 years in hospital. Of the 17 who spent less than 10 years in hospital, the mean length of hospitalisation was 24 weeks. These were indeed experts. Respondents were asked to describe the main people who had supported them in their recovery. Family was cited most frequently, on 21 occasions, followed by mental health professionals on 19 occasions. Friends were cited as supportive of recovery by 12 people, peers and other service users by 9, and groups and organisations by only a few. Respondents shared their own definitions of mental health recovery. The most dominant themes embodied in these definitions were transcending the need for psychiatric services, living with oneself and finding personal meaning. Several respondents stated that not taking or being reliant on medications, some also mentioned illicit drugs, was important to their recovery. Others suggested that developing tools to manage mental health and to resist being engulfed by discourses of mental illness or stigma that position them as, I quote, helpless, deficient, hopeless or chronic. Living with oneself and deriving satisfaction from life, relationships and activities was described by most. For example, for me recovery is about discovering who I truly am and want to be, to feel happy in my own skin, and despite having changes in mood and thoughts occasionally, having the strength to remember and return to a norm I choose and a life I want to live. For many, living well was framed in ordinary terms, with people stating, for example, having more good days than bad days, living at home, socializing, and feeling hopeful some or even most of the time. Most respondents spoke of recovery involving some form of personal discovery, ongoing learning, or finding meaning and worth in everyday activities. For some, having choices, being self-determining, or taking control of one's life was crucial. Others spoke of recovery in terms of reclaiming something that had been diminished or lost through their experience of distress, for example, hope, humour, joy, enthusiasm, stability, strength, or balance. The experts rated the 103 competency statements on a scale of 1 to 7, 7 being extremely important to realising recovery. There was substantial agreement between round 1 and 2 ratings, an R of 0.98, and near consensus around those statements that were rated most important. Individuals were positive in their overall ratings, with mean ratings between 4.88 to 9 to 6.95. All competencies received at least one rating of 7. That is extremely important. The 18 top-ranked competencies all received a mean rating of 6.6 or above and a high level of agreement. I'll just explore the top 5 and then make some observations about the top-rated competencies generally. The first ranked competency statement was a competent mental health worker recognises and supports the personal resourcefulness of people with mental illness. Some panel members stated that it reflected the fundamental attitude and skill to assist people to recover, that mental health workers needed to see, acknowledge and work with people's strengths and abilities rather than their limitations. Some commented that recognizing the resources that people possess, for example supportive relationships, untapped skills, dreams and aspirations, is the first step in mobilizing those resources. Some also said that taking the time to really know and understand the person was necessary to realize the competency, and described individuals, for example workers, other service users and mental health workers, who, as one person suggested, know when to push and when to hold. Some respondents provided examples of small practical gestures that made a difference to them. For example, my mental health social worker encouraged me to plan my own weekly activities with my young baby when recovering from puerperal psychosis. Further down the line of recovery, she also gave me the rap for my husband and I to fill in for ourselves. A worker from the community resource team recognised my enjoyment in particular with line dancing whilst in recovery, and made a point of ringing and inviting me to sessions of Keep Fit to participate in while I was in recovery. The second most highly rated competency was to work in a recovery-focused way. Mental health workers needed to reflect a belief that recovery is possible. Several people pointed out that workers needed to be mindful of what is meant by recovery. That recovery does not mean being free from symptoms, but in most cases learning to live with certain experiences and being comfortable with whom they are. This competency was deemed important to engender hope. People spoke of mental health professionals who communicated their belief that recovery would happen, sometimes despite feeling pessimistic themselves. For example, I always remember a conversation I had with a nurse where he had so much belief in recovery from me. I had a home, a job to return to, and that has remained with me. His belief in me and recovery helped me so much. The third and fourth highest rated competencies were closely related. To work in a recovery-focused way, mental health workers need to be able to listen to what service users are actually saying and respect their views. And to work in a recovery-focused way, mental health workers needed to respect for the expertise and unique knowledge gained as a result of having experienced mental health problems. Respondents provided examples of health professionals listening to them, sometimes disagreeing, but acquiescing to their wishes, for example, to stop or reduce medication, or negotiating a course of action that reflected a compromise in relation to the person's wishes and the mental health worker's recommendations. Several people acknowledged that they might be considered experts by experience, and that this expertise needed to be tapped. It is unclear to what extent mental health workers ought to lead or follow the service user, and how the stance is related to the person's stage of recovery. One respondent stated, "My CPN has stated she is guided by me at the moment, as I would class myself as recovered currently, and I feel my voice is very much heard." The fifth rated competency was, a competent mental health worker helps the person develop self-belief, therefore promoting their ability to help themselves. Respondents suggested that using strengths-based approaches or simply being encouraging demonstrated this competency. Another suggested that providing opportunities for the individual to help, support others in distress, and or contribute to a group or organisation helps a person to develop self-confidence. So, what to say about this exercise? With only a few exceptions, respondents rated the competencies positively, that is, as important or very important in assisting people in recovery. This may be seen as an endorsement of the competency sets themselves. However, it might also be seen that there is little to discriminate between competency statements, or between some principles of good practice and recovery-focused practice. Recovery-focused competencies and practices, like non-specific factors in psychotherapy, may be subject to the dodo verdict. That is, everybody has won, and all must have prizes. Further critical reflection and debate is also warranted on the congruency of competency statements, derived as they are from a positivist paradigm, with the more postmodern notion of mental health recovery. Similar tensions between evidence-based practice and recovery. Some might reasonably ask, do mental health workers who demonstrate the competencies described really make a difference to people's recovery, and how can this be demonstrated? This study asked individuals to consider what made a difference to them, rather than conflating various ideas of objective clinical or functional recovery with subjective notions of personal recovery described by the respondents. The top-ranking competencies did especially emphasize recognition and promotion of an individual's capacities, strengths, resourcefulness, and autonomy. This suggests that coercive or controlling practices may sit uncomfortably alongside, or in some cases may be incompatible with recovery-focused practice, at least as recognized by this panel of experts. For example, it may be hard to argue that forcibly restraining someone and administering medication to them against their will is a recovery-focused practice, despite whatever beliefs might be held by the mental health worker involved about the individual's capacity and likelihood to recover, or whatever moral or legal justification might be offered. The kind of directive stance that might be needed of a helper in a crisis or emergency situation may not be incongruent with recovery-focused care, but it is something different from it. Thus, recovery-focused and competent care may be a subset of good care, but it does not subsume all that is good. Many people will need good quality, time-limited crisis intervention, or to consult with technical experts in medication management. These may be needed and provided in a mental health system, but these in themselves are not recovery-focused practices. may also be morally defensible for mental health services to provide for the basic needs of people, provide accommodation, food, etc., and sustain a dependency in those that receive care. I suggest that this is also not recovery-focused care. I also suggest that some of the technologies employed in helping, standardized tests, routine standardized outcome measurements, routine use of medication in high prevalence mental health problems, dehumanizing processes, etc., are difficult to reconcile with recovery-focused care. Clarifying the boundaries of recovery-focused care might crystallize our collective attention on those things that are incompatible with mental health recovery. I think the credibility of the experts in commenting on recovery competencies is affirmed by their testimonies that others have been helpful in their recovery journeys, including mental health professionals and mental health workers. Indeed, sometimes long before the term mental health recovery gained any kind of currency. This is reassuring. There have always been compassionate and skilled people that are inclined to help people and do it well. In New Zealand, I loathed the competencies when they were introduced. I was a teacher at the time. I'm just not keen on this reducing and standardizing things generally, but have to concede that it was useful developmentally. They probably had no impact on doctors, who have a tendency to play in their own room with their own jewel-encrusted toys. They did, however, make a huge difference in developing a mental health support workforce. My impression is that they contributed to changing the ethos of mental health services. So specifying competencies may be helpful, at least developmentally, to raise the prospect that all service users might encounter health professionals who assist them or facilitate the right conditions for mental health recovery.